This is part 2 of the lecture on pain, and it will cover the pharmacological management of pain. And again, I must acknowledge that these slides came from SlideShare. Now, one of the most often used pain therapies are opioids. And during the 19th century, morphine was isolated from opium, and its pharmacological effects were characterized by the opioid receptors that it impacted. And the mu receptors are highly selective for opioids. The delta receptors are mixed agonist-antagonist receptors, and the kappa receptors, opioid analgesics are selective for these receptors but not really identified. Now, full agonist opioids bind to opioid receptors, the mu receptors, and block substance P, which prevents the transmission of pain. There is no ceiling on the analgesia, which means that an increase in dose leads to an increase in pain relief, and there is no maximum dose for these categories of drug. Mixed agonist-antagonist bind to mu as an antagonist, which means it does not produce analgesia, but it binds to kappa as an agonist, which means it does produce analgesia. There is a ceiling effect, and you can get withdrawal symptoms with these drugs. Partial agonists bind weakly to the mu and kappa, but they are not easily reversed by naloxone or Narcan. And antagonists compete with opioids and block analgesia. For example is Narcan, which has been a lot in the news lately because of the opioid epidemic that we have in this country. Now this is just a picture of the location of the different opioid receptors, and you can see that they are throughout the entire central nervous system. Opioids are also classified as whether they're weak or strong, or whether they're partial agonists, pure agonists, agonist-antagonists, or antagonists. For example, tramadol and codeine are considered to be weak opioids, whereas morphine and oxycodone are considered to be strong. And Narcan or naloxone is considered to be a weak antagonist. What we're mostly considering here are the pharmacological effects of opioids, and we're going to talk about the management of those in a minute. On the central nervous system, it can produce analgesia, which is what we want to do. We want to get rid of the patient's pain. But it also can cause dysphoria, meiosis, physical dependence, which we're going to talk about at the end of this opioid section, respiratory depression, and sedation. On the cardiovascular system, it causes a decreased myocardial oxygen demand, which is a good thing if your patient has come into the ER and is in the midst of having an MI. It also can cause vasodilation, which can lead to hypotension. On the gastrointestinal system, we have constipation, nausea, and vomiting. And a frequent side effect is the genital urinary system, where you have increased bladder sphincter tone and urinary retention. As far as the neuroendocrine effect goes, there is an inhibition of the release of luteinizing hormone. If you remember, luteinizing hormone triggers ovulation and the development of the corpus luteum in women, but it also stimulates the production of testosterone in males. Another neuroendocrine effect is the stimulation of the release of antidiuretic hormone and prolactin. Now we're going to talk about antidiuretic hormone in a later lecture, but it will actually increase the amount of fluid that is retained in the body, which can lead to hyponatremia. And prolactin actually stimulates lactation. The immune system effects is a suppression of the function of natural killer cells. Natural killer cells are important in running throughout the body and ridding it of cancer cells. And there are the dermal effects of flushing, pruritus, and urticaria. Now these next two slides are just charts that talk about the different opioids, their chemical source, relative histamine release, which would be important if they're going to cause itching, the route they are given, the equal analgesic dose in adults, and the onset and half-life in minutes and hours. The ones that I would probably pay particular attention to are morphine and Dilaudid, fentanyl, and on this slide, probably the Narcan. Most particular to nursing care is going to be the management of opioid adverse effects, because you definitely want to decrease your patient's pain, but you want to make sure that the adverse effects aren't going to make them suffer also. So for excessive sedation, what you can do is reduce the dose by 25% or increase the dosing interval. For constipation, you can give the Casanthrol and Docosate, 1 capsule at bedtime, the Senna, 1 to 2 tablets at bedtime, Bisocodyl, 5 to 10 milligrams daily, plus Docosate, 100 milligrams. Now, if they are suffering from nausea and vomiting, you give hydroxyzine, 25 to 100 milligrams PO or IM every 4 to 6 hours as needed. Diphenhydramine, 20 to 50 milligrams PO or IM every 6 hours as needed. Ondansetron, 4 milligrams IV or 16 milligrams PO, up to 4 to 8 milligrams every 8 hours as needed. And prochlorperazine, 5 to 10 milligrams PO or IM every 3 to 4 hours, and 25 milligrams per rectum. For the gastroparesis, you can give metoclopramide, 10 milligrams PO or IV every 6 to 8 hours. For vertigo, meclizine, 12.5 to 25 milligrams PO every 6 hours. Hydroxyzine, for the itching, 25 to 100 milligrams PO or IM every 6 hours as needed. Diphenhydramine, 25 to 50 milligrams PO or IM every 6 hours as needed. And as I said before, for respiratory depression, you can reduce the dose by 25% or lengthen out the dosing intervals. If the respiratory depression is severe, you're going to give naloxone, 0.4 to 2 milligrams IV every 2 to 3 minutes, up to 10 milligrams, or 0.1 to 0.2 milligrams IV every 2 to 3 minutes until the desired reversal. You have to be careful with naloxone because you can have a patient go from respiratory depression to agonizing pain because it will block all the mu receptors in the central nervous system. If they have CNS irritability, you're going to have to discontinue the opioid and treat it with benzodiazepines. Now, there are many drugs that interact with opioids, especially the ones that cause the central nervous system depressants, such as alcohol, anesthetics, antidepressants, antihistamines, barbiturates, benzodiazepines, and thiothiazepines. They have an additive depressant effect, so you're going to have to watch if your patient's giving opioid therapy and any of these other medications. Now remember, you don't want to give meperidine, which is Demerol, plus an MIO inhibitor because it results in severe reactions such as excitation, sweating, rigidity, and hypertension. Now there's some points to remember about opioids, especially in the face of the opioid epidemic that we're having in this country. So I want to talk about titration, dependence, tolerance, and true addiction. Titration is just the giving increased or decreased amounts of a drug so that the smallest dose leads to satisfactory pain relief with the fewest side effects. The amounts and frequency depend upon the drug onset and the peak. Dependence, when we're going to talk about physical dependence, is a normal response with repeated administration of opioid for several days. It is manifested by withdrawal symptoms if the dose is not gradually reduced. It is not the same as addiction. Tolerance is another normal response. With regular administration of opioids, there's decreased analgesia, which usually occurs in the first days to 2 weeks. Then the dose usually is stable. Most dose escalations are not related to addiction, but are related to disease progression. Now, addiction is a chronic neurologic and biologic disease. It is characterized by continued use despite harm, impaired control over drug use, compulsive use, and craving. So, your cancer patient who is on an opioid and the disease progresses and they require more and more opioid to alleviate their pain and suffering is not addicted. Now, non-opioid analgesics are probably what you're most familiar with, and they are non-steroidal anti-inflammatory drugs, or NSAIDs. The characteristic features of these drugs is that they relieve pain without interacting with the opioid receptors. They possess anti-inflammatory properties, have antiplatelet activities, do not cause sedation and sleep, and are not addicting. These are all of the different types of non-steroidal or non-opioid medications. The two that I want you to know quite a bit about are acetaminophen or Tylenol and ibuprofen or Motrin. These are the prototypes of the drugs. Now, acetaminophen is a non-opioid analgesic but has absolutely no anti-inflammatory properties. It is given for mild to moderate pain and often in combination with opioids. The most serious complication of this drug is hepatotoxicity. There's a low incidence of GI bleeds, and the maximum dose should be about 4,000 milligrams per day. And if it's taken long term, such as elderly people who may be taking it for arthritis, it shouldn't be more than 2,500 to 3,000. Now, when you're doing your patient teaching with patients who take continuous doses of Tylenol, you must educate them that they need to count up all the milligrams they're taking, because Tylenol is put in a lot of over-the-counter medications. And you can easily cause fulminant liver failure, which we're going to talk about when we talk about liver disorders, if you overdose on that drug. It can actually lead people to have a liver transplant. Ibuprofen or Motrin is the prototype of NSAIDs. It produces analgesia and has anti-inflammatory properties. Adverse effects include GI toxicity and bleeding. There's also cardiovascular risk related to prostaglandin inhibition, which we're going to talk about on the next slide. It should not be taken after open heart surgery, and it also affects renal function. So you have to make sure your patient is well hydrated. Teaching with this type of drug is that you want to have them take the medication with a full glass of water and take with food to decrease the GI symptoms. Now this is how NSAIDs work. Cyclooxygenase is found in all body tissues and helps regulate processes. At sites of tissue injury, the cyclooxygenase, or COX, catalyzes the synthesis of prostaglandins, which promotes inflammation and sensitizes receptors to painful stimuli. NSAIDs actually block the COX. Now, these slides are also important for you to look over. What I want you to pay particular attention to is, as I said before, the acetaminophen, and you should look at the acetylsalicylic acid, which is aspirin. And on this side, you might pay particular attention to naproxen. Now, adverse effects of non-narcotic analgesics again include the gastrointestinal system, with nausea, abdominal pain, dyspepsia, constipation, vomiting, hematochezia, intestinal obstruction, intestinal perforation, pancreatitis, peritonitis, peptic ulcer disease, and diarrhea. Hematological effects can include, and they're very serious, aplastic anemia, leukopenia, neutropenia, pancytopenia, and thrombocytopenia. And they can also cause malignancies, such as the lymphomas. Renal effects include interstitial nephritis and impaired renin secretion, and enhanced tubular water and sodium reabsorption, so you can get edema with these. They're also implicated in infections such as sepsis leading to death. And malignancies and infection are a result of the tumor necrosis alpha inhibitors. Now, drugs that interact with nonsteroidals are aspirin and oral anticoagulants. They can cause gastric and mucosal bleeding and an increased risk of bleeding. Salicylates and methotrexate, they block the methotrexate tubular secretion by salicylates, resulting in pancytopenia or hepatotoxicity due to increased methotrexate. NSAIDs and the tumor necrosis blocking agents can lead to neutropenia. Now, another thing you might want to be aware of is the World Health Organization analgesic pain ladder. So when you have a patient who has mild to, I'd say, moderate pain, you begin with a non-opioid, such as an NSAID. With increasing levels of pain, you add a weak opioid plus the non-opioid, and with pain that is really intense, you use a strong opioid plus a non-opioid, because you want to block the pain both in the central nervous system and in the peripheral nervous system, blocking the COXes. Now, common causes of analgesic treatment failure include inappropriate or unknown diagnoses. You can have improper medication selection, such as using a nonsteroidal for abdominal pain that might be related to a GI bleed. You can have a misunderstanding of the pharmacology or the pharmacokinetics. You overestimate the potency or the half-life, which means dosing an opioid less frequently than necessary to provide adequate relief. You can have inadequate management of adverse effects, so that the patient might just discontinue the therapy or misuse over-the-counter remedies. The patient suffers from constipation from antidepressant and uses the daily bicyclodal. Fear of addiction. This is a big one. The physician or the patient or the caregiver may withhold medications. Now, there's evidence of tolerance after chronic use of opioids, but remember that is not addiction and it can be mistaken for addiction. There's unrealistic goals for therapy. The patient will not be satisfied with pain management regimen and may seek other care. Patients have a desire to be pain-free following significant nerve injury. What you need to do is to find out what the patient is able to tolerate. And there's irrational polypharmacy, over or under use of appropriate therapies. An example is a patient with neuropathic pain using 3 different opioids without any adjuncts in the regimen. Patient barriers. The patient can't understand appropriate medication or other pain management. They have language, cognitive, physical impediments, or cultural barriers, and a lack of understanding of the pathophysiology of pain. The limitations of the healthcare providers to actually adequately relieve pain. An example, drugs that show benefit in animal models are not useful for humans. Now we need to say a little bit about adjuvant therapies. As far as anticonvulsants go, they block sodium and calcium channels in the central nervous system, which diminishes the transmission of pains. For example, Neurontin, which is used for neuropathic pain. Antidepressants block the reuptake of inhibitory neurotransmitters, norepinephrine and serotonin. These include the tricyclic antidepressants, for example, Elavil, or the serotonin norepinephrine reuptake inhibitors, and they're also used for neuropathic pain. Local anesthetics actually block pain signals. In high doses, they cause anesthesia, but in low doses, they cause analgesia. For example, lidocaine patches and also topical creams such as capsaicin. And finally, steroids are actually given to reduce the inflammation. And this is my short lecture on the pharmacological management of pain.